to introduce Dr. Maxine Hayes, who was chair of our national leadership team for our initiative and is leading our racial equity leadership group.
Thank you, Charlie. And let me just say that I am so happy to be not only here with all of you, but then to welcome people who have not been with us before today. And we are very pleased with that, a very good mix of people, policy, practice. And so I feel that we're making some headway. Let me just start by saying that the integrated care for kids, our Inc. marks, was supported by Robert Wood Johnson for 6 years. And what has happened in our community is that we have old tools for new challenges when we take care of children and their families. And we need to really transform the culture that we have with the focus on health, but recognize that the contributions to improving child and family health and community health lie with what we try to do for all of our kids. And so the culture of transformation, whether it's practice, the measures, we need to really go from the conceptual to the operationalizing of these practice changes. And I want to just refer you to the website to really go deeper with that. But there are 3 things that we learn from our work with healthcare transformation. And that is the role of children in this is enormous, not only for equity, but for population health. This health system can play a really important role in this. And we have to prioritize children. There's no way we can get to equity without realizing we have to go as far upstream as we can get with children and their families. And we know what works. We have done extensive evaluation of what's in the literature, and we need to use that information, build on that. And that's where we come to the need for community health workers and requiring a new standard of care and investing in the public, taking public investments for primary child health care and also community health. These are the things we've learned. These are the things we need to be applying in one voice: prioritize kids, build on what works, and invest in value. And I say value as opposed to expenditures because it is an investment. It is an investment, and the outcome and dividend is going to be not only with the child, but with the community. So this is the Child Health Racial Equity Leadership Group, and you'll recognize many of the names here, and others are still joining. We want an opportunity, and we've been given an opportunity right now with Congress, with the fact that we all want to build back better, with this same message. We can't get to equity without starting with our kids. And in those families, the family is the first community that a child has. We need to do everything we can to develop relationships that will nurture that in the parenting role. And we need to be able to invest in our families. And those are the messages. When we know what works, we want to apply that. And I'm excited about what I think will be the opportunity for the federal government as well as within the states. So with that, I'll segue to Charlie Bruner.
Well, thank you very much. And Maxine's been a mentor to me and a longtime friend from 1988 onward. And we really do see this as an opportunity. And people may say, you spent 6 years researching and came up with those 3 findings. That seems like a lot of time to come up with things that are basically pretty obvious. And really, we condense down what is a whole lot of research and analysis to come up with those conclusions. And we think that they should be obvious, but they aren't now reflected in our policies and the way we make investments in healthcare overall. And we tend to think about healthcare as a medical model and a therapeutic treatment for specific disease and not in a broader context. So we really think that getting that message down is something that we can all participate in. We urge you to do so as well. I'm going to talk about child community health workers from the context of our work and where it fits. And really starting with the question that if you ask practitioners or if you ask departments of public health or if you ask people in the community, who has the day-to-day responsibility, expertise, and authority to engage with children, families, and their communities in order to ensure families are trusting of the medical practice and children get the needed health care and medical care they need, to ensure that we respond to crises and social vulnerabilities in poor and underserved communities, which often are marginalized away from sources of support, that we ensure that healthcare and public health are part of the solution in advancing racial equity and responding in culturally reciprocal ways. If we really want to engage and elevate their voices of those children and families in planning and policy, and if we want to integrate the health system's responses with other community services and resources to respond to social determinants of health, you say, who has the day-to-day responsibility, expertise, and authority to do so? In many instances, people say we are doing the best we can under the circumstances and who we have in our office. But we feel like this is a weak spot in what we're doing. And we really would like to have dedicated, knowledgeable people, staff who really are the responsible for the expertise and authority. And so really that gets to the answer to that question, who you're going to call is community health workers in many efforts. And when people talk about we need a systemic approach, those community health workers are on the ground making sure that for families and kids being served, they get to what they need when they need it within the community, and it's integrated. It's a systemic frontline approach. When you look at the science and research, it's clear that building this through the trust and the relationships of community health workers is key to success. And we have a wealth of literature across medical care and social work and child development that says that. And we know that it really is holistic, and it's something that those workers are doing that are building upon strengths and caring for the family and the kids and helping them to realize what they want in their lives and in their roles as their child's first nurturer and safety officer and educator and nurse. So we know that this is something that is core. And I'm going to go through very quickly 5 questions about why community health workers and children, because a lot of times community health workers are directed toward people with chronic healthcare needs, and that's important. But there's a special place, I think, for community health workers and kids. So I'm going to go through each one of these 5 questions. And we really have a wealth of information, and INCMARC's with its work with 45 other organizations and really mining the field, saying we can answer these questions quite definitively and affirmatively. So what do we know about the importance of focusing upon children and advancing population health and reducing racial inequities? Well, first, kids are the most diverse age group in society. And so if we want to address racial equity, we have to look at who are the most diverse, and that is kids. So just by numbers, we go there. But brain research also shows that when we're looking at responding in ways that get not to the medical care, but to the social determinants of health, which could be issues around development of self-regulation, behavioral and emotional health and well-being, self-regulation and support. We know brain research shows the opportunity for our growth and change is the greatest at certain periods of life, and they really are with kids, or in many respects with initial parenting. We also know that when we make a change, the impacts have the longest duration. And for people in my age group, we're going to be living sometime longer, hopefully 12 years for me, but kids have 69 years ahead of me. The impacts are just going to be really there for years and years to come. And then finally, really, we know, and Maxine talked about going upstream, and what Frederick Douglass says, it really is easier to raise strong children than repair broken men, that really this is the area where we have the most realizable opportunities for change. So I think that that question about why focus upon kids is really clear. Well, one of the things that community health workers really are seen as necessary for, or as working with, poor and medically underserved neighborhoods and communities, places where people need additional support. The social determinants, the community fabric is frayed and is not there. If you look at children in medically underserved neighborhoods, and we've used the the Center for Disease Control's Social Vulnerability Index to look at the 31 million people who live in the highest vulnerability areas compared with the population as a whole, and say, this is where community health workers are most needed. You can see they have a quarter more children than per capita than the population as a whole, and a third less seniors. So again, just in terms of numbers, when you go into these neighborhoods, what you see is a lot of children and their families, and you have to be geared toward doing that. You also see that these are racially quite concentrated and often marginalized away from sources of support. And that's 78% of the population, which is BIPOC, and it obviously varies by different populations. It could be a Myanmar population in one neighborhood, an African-American population in another, or a mixture of several ethnicities in a third. We know that we have to be able to relate there, and they're going into the community and having the community knowledge and the background and understanding, which community health workers do, is really a necessary way of bridging with health systems. And finally, while these SIA census tracts represent 10% of the population, 39% of all kids of color live in those neighborhoods, and a much higher proportion of those who are most vulnerable, because they're most likely to be poor and in poor and underserved neighborhoods. That's where we have to go. So I think the question, we know that the special role for community health workers in working in high, poor and medically underserved community is going to be a lot about responding to children and their families. The third, what do we know about the role and effectiveness of community health workers? There's a recent meta-analysis by the International Health Research and Policy Systems, and it simply says the evidence is incontrovertible that properly designed, implemented, and supported community health workers are key to establishing high-performing health systems, even in developed countries. And here are different, very recent reports from different groups in the United States around this. The first two are specifically about children, one by INCMARCS and one by the Children's Partnership, which Myra heads and is a co-author of. But we have a tremendous amount of research and knowledge, deep and compelling research based on the effectiveness of community health workers when those programs are properly designed, implemented, and supported. The fourth question is, what do we know about the specific role of community health workers working with children and their families? I'm not going to say much about this because Pradeep David, who have done this work, and others are going to really explain, but we have multiple evidence-based workforce additions within both public health and primary healthcare practices show they make a difference. We have multiple primary child health practice models that incorporate community health workers or this care coordinator, relational care coordinators as a part of that. We have whole systems change. And again, Pradeep is going to speak about San Diego County and their work. And we know that these have those common attributes that really relate to a lot of things about regarding these frontline practitioners or community health workers as essential agents of change. So we really try to say we know enough to act, and that build on what works. Not only do we have these out there, we have people who are doing it now and can be role models, mentors, and providers for others to do it. So we do know that there's a very specific role of CHWs working with children and their families, and it has tremendous impact. The fifth question is, what can we build on in terms of federal policy commitments and goals? And I was very excited when President Biden and in his campaign came out with the 21st Century Caregiver and Education Workforce plan, where he specifically said we need 150,000 additional community health workers, and I'm going to invest $6.5 billion annually to put those in place. And I'm going to make sure that they're better resourced, compensated, trained, supported, supervised, and that it's implemented well. And now we have Senator Casey really secured bipartisan support with Senators Tillis Smith and Murkowski on building a sustainable workforce for healthy communities act of 2022, but it's also in other members of Congress activities have said this. It's not necessarily focused on kids, and it's not necessarily having all the safeguards or the direction that is going to ensure that the well implemented, but we have what is really a set of people in Congress who say this really is important, and now we need to move forward with it. I added one slide. It's not just at the federal level that we're talking about this, and David Willis was working with Washington State, and then Myra is going to talk about California's work, but Washington State just passed legislation to give attention to advancing community health workers for children. And I think that, and Senator Murray, who is the chair of the Health Committee, is from Washington State, that this is a real opportunity to look at how we can have federal policies coordinate with state policies to really maximize investments in community health workers as part of both a public health system response and as part of primary child health care practices, which this authorizing legislation really brings into focus. And as I said, we're going to make available these slides, so I'm not going to go on more detail on them. I think that simply the key issues moving forward are that, and going back to that meta-analysis, scientific evidence is incontrovertible that when properly designed, implemented, and supported, CHWs are an essential component of a high-forming healthcare system. And what you're going to hear from now is first from community health, people who work in the community health worker field. What does that mean, and what do we need to put in place? And how do we do this practice in a way that really does support healthy development of families? Then have the same from the health practitioner perspective, what needs to be in place from the advocacy perspective. And then last, to really have Kate provide an overview of the thinking and the work proceeding in Congress, and us to have a dialogue on how we can all help make sure that it moves forward and realizes its full potential. So I'm going to turn this over now. I think Brianna is going to start, an MSW who's from Bristol, Tennessee, and works largely in Virginia, but is also part of a team with the Penn Center for Community Health Workers, really advocating for movement. Brianna?
Hello, everyone. My name is Bree Burke, and I'm a community health worker at a nonprofit organization called Healing Hands in Bristol, Tennessee. We're actually a twin city, so we're Bristol, Tennessee and Bristol, Virginia. So our small clinic provides primary care to non-insured patients, and we also have a dental clinic that treats non-insured patients as well. Y'all have to excuse me. I'm feeling a little under the weather, so I'm trying to pull through. All right. So before I came to Healing Hands, I was a community health worker at a larger hospital system. And in my opinion, the hospital was kind of quickly changing their CHW model to really help. They were kind of focusing on just health issues and not allowing the CHWs to really help their clients with the core issues they were struggling with. So Healing Hands has definitely given me the opportunity to move forward with helping patients in the way that I feel that I need to make them become the happiest and healthiest version of themselves possible. So I'm very excited to be with you all today and share about the community health workers, who we are, what we do, and what difference we make. So first, I want to say that community health workers are the missing link between community and healthcare. We can get to know people where they are, find out their life story, the things that made them who they are, and then be that support person for them to get them where they want to be. And with that being said, I want to share a patient story with you all because I just feel like that patient stories are the most important thing that you all can hear from me today. So I met a community member at a bus stop while I was handing out food for the homeless with a local organization. One of the members recognized her immediately and asked her if she was hungry. And she came up and was talking to us, said, "Yes, I am hungry. But I have some news to tell you all." She was like, "I just got done with an interview and it went great. And I think I am finally headed up the ladder. Like I am getting off the street. Everything's going to go great." So I gave her the food box, handed her my card, told her just briefly who I was, what I did, and just said, if you need extra support, call me. I would love to work with you. At that time, community health workers were very new to the area, and we were still working on how we were supposed to get patients. And this one just so happened to fall in my lap. So I received a call from her about a month later, and we scheduled a meeting. She told me her life story about growing up in a mentally and physically abusive home, falling in with the wrong crowd at school. She started dating a guy, and then they both started doing drugs together. But it was obvious from the beginning. She told me about her children who she surrendered to respite care through social services while she attended 3 months in jail for a domestic dispute and then had to complete 3 months in rehab to try to get off the drugs that she was on. She was supposed to be absent from them only a total of 6 months with Zoom visits set up weekly so she could stay connected with them. But unfortunately, during COVID's actually started while she was in jail. So she lost complete contact with her children while she was there. Her significant other was supposed to pick the kids up once he finished his 3 months jail time because he did not attend rehab, but he did not show up and unfortunately disappeared. She tried desperately the minute she got out of jail to get a hold of someone that knew anything about her children, their location, where they could possibly be, but everyone was working remote and she could not get a call back. She sent certified letters. She left voicemails, went to the office, but like I said, COVID had just started. Nobody was there and she wasn't getting anywhere. I asked really quickly about her medical issues. What medical things do you have? Do you want to do counseling? What can we work on with you while I'm trying to reach someone about your children? And she wouldn't even hear of it. She could only see the big picture stuff. And to her, that was getting her kids back and connecting with them somehow. So I quickly regrouped and was like, okay, so my first step needs to be, I need to confirm her story. So I talked to all of her supporters, her PO officers, her rehab personnel, lawyers, and they all collaborated her story and said that they had tried desperately right alongside her to reach someone that could tell them where her children were and if she had heard and they never heard anything back from them. So I quickly went to work trying to get in touch with the department. But in the meantime, my client and I had to search for apartments because remember, she was still homeless at the time. She finally found one that was in her budget and she moved in, but she had absolutely no household items. She had lost everything. So I was able to get her connected with a community group that completely furnished her apartment, and that is including her kids' bedrooms, so she could get a complete fresh start when she did get her kids back. I helped her work on the house with decorating, setting up furniture, putting together beds. It wasn't long before her house looked like a little home, but her babies were still missing, and that was still her main focal point. So finally, after several weeks of failed attempts, we reached out to a supervisor with DSS and were able to set up a meeting to see how she needed to move forward to see her children. With my support and encouragement, my client hired a new lawyer, and weekly visitations started within just a few weeks after that. Once we got everything sorted out with her children and she was able to see them again, she was able to focus on herself for a minute. We talked about how, in order for her to be the best she could be for them, she needed to be able to be healthy, make sure she was getting any kind of counseling that she needed. So we were able to get her set up with a primary care doctor, and she started weekly counseling immediately. During my time with her, I attended child visits, court dates, counseling sessions, church services, rehab meetings. I did it all with her just to build that trust and a relationship with her so she knew she had the support she needed to move forward. So now my client gets her children unsupervised every weekend and is looking to have them placed back in her home permanently this summer after her oldest gets out of school. This client is not the only one that I've worked with concerning the foster care system. She is just one of the stories that I've chosen to tell, which brings me into some challenges. In my area, Southwest Virginia, Northeast Tennessee, we found that children are taken, when they're taken from the home by CPS, they are surrounded with tons of resources. They have the foster parents, the social workers, they get counselors, court-appointed special advocates, guardian ad litems, which is absolutely exactly what should be. I'm a foster parent myself, so I understand the need for surrounding them with all the love and support you can get them. But unfortunately, the parents normally only have the social worker, who is not only supposed to oversee the case, oversee the children, come up with a plan for the family as a whole, but to also come up with a plan for the parents to work on to be able to get their children back. And unfortunately, that support sometimes looks like a reminder call to complete the things on the list. So not really a ton of support. If the goal is return home, because that is supposed to be the best possible outcome for the whole family, we need to work on surrounding the entire family with the supports they need. Not supporting the parents as much as the children during this time means the entire family will suffer trauma. Like in the story, the children were absolutely devastated. They thought their mom had deserted them when she was trying the whole time to get a hold of them. I'm sorry. Having community health workers work with people in the foster care system, work with social workers, work with the health departments can completely change how a whole case goes, because we can get in there and find out what it is that's going on with these clients, what it is that's going on deeper than what they will tell a doctor, or they'll tell a social worker, or they'll tell a case manager. We get to know them exactly where they are, and we get to expand on that and figure out how we can help them to their actual goals. And what is the most important thing to start moving forward with getting them to their actual goals. The story I shared shows that community health workers are needed in many different healthcare facets: doctors' offices, hospitals, health departments, and in the social working field. CHWs can determine why parents are not able to follow through. We are needed to see if we can help navigate the road for parents to break those traditions and lifestyles that make them not successful in being a great parent, and figure out how we can support them while they learn and grow into the parent that they want to be. I've learned with the parents I've worked with, their bad habits are sometimes due to untreated health or mental health issues, and they are just needing someone to listen so they can help them get the treatment that they need. One of the main challenges is that there are not enough CHWs in the field that we need to be in, due to the fact that we are not compensated well enough for the work that we do. I have personally seen several of my colleagues leave the CHW field due to higher paying jobs. And I'm not talking about jobs with degrees. I'm talking about local fast food restaurants, local call centers, and local factories willing to pay well above what we can make being community health workers. The CHW work is so important, and it takes a very special person to be able to do it. But if we don't find a way to fairly compensate them for all that they do, I'm afraid that we will never have enough CHWs to fulfill all that we need in our communities. Thank you.
Bree, thank you so much. This is Elizabeth, a proud CHW ally. I have no idea what I could say that would be more impactful than what Bree just said, but just to pull on a couple of threads, what Bree described, her patient-centered approach, all of the amazing resources that she provided to her patient, that's a lot because she is sitting in a very well-supported and well-funded CHW program. And so as we advocate for expanded funding, we can't just think about money. We have to think about money going to programs that let CHWs do their best work. So just throwing money at the problem or thinking about it as a checklist of services and not enabling people like Bree to think about clients as whole people with kids and medical needs and every possible need they could confront, that's what we're advocating for in our Community Health Workers Advocating for Movement group. And so we're pulling on three things here, three work streams. Kate, thank you for being on. We'll talk about some discretionary grant funding opportunities. And then we're also interested in expansion through the Medicaid program and additionally through Medicare, which is less relevant to this call, but it was in the president's budget this year to have Medicare coverage for CHW services. So in each of these work streams, there's some tricky questions about who should get that money and what supervision should be provided. So it's really, really important that we have CHW voices at the table and that we're able to lift up Bree and all of her colleagues to help lead this work. So I will just put in a plug for our group. I will put my email and Bree's email in the chat. We would love other CHWs and allies to join us. And I would be remiss not to give a huge thank you to NACHWA. I don't know if anyone's on from there, and APHA for being our guide in this work and lending so much expertise to us in terms of shaping policy at the federal level. So thank you for having us. Thank you, Bree, for your comments, and I look forward to the rest of the discussion.
Well, thank you, Bree and Elizabeth, both. And I think that gives a great introduction to why they work and what makes this really the key element and why we have to incorporate it into practice. And one of the things in incorporating into practice is incorporating it into primary care, and particularly for young children, who sees the child during the first 3 years of life as a professional who can respond or provide a warm handoff to community health workers to respond really is the pediatrician. So delighted to have Pradeep Gidwani and David Willis give their perspectives on what primary care, how we can support primary care and ensure that primary care can really effectively engage and work with and resource community health workers. Pradeep?
Thank you, Charlie. Just to start off, I think one of the things that's really important, as Charlie has mentioned, is the pediatric office is where so many families are met. And there's so much potential for what we can do with the pediatric office. And we also need to rethink how we deliver pediatrics. In San Diego County, through the funding of First 5 San Diego, we've been running a program called Healthy Development Services for the last 15 years. And we actually treat kids with mild to moderate developmental and behavioral concerns. To be able to do that, we have to address the social determinants of health as well as the ACEs. And our community health workers are our care coordinators, who develop a relational interaction with our families that has been critical. And as Bree mentioned, they find out the things that we can't find out as pediatricians because of the closeness of the relationship even from a cultural perspective. And so some of the points I'd like to make is that the community health worker needs to be a valued part of the care team. We actually have been able to do this with care coordinator community health workers who are part of the internal team of a practice, but we've also been able to do it where they're not part of the internal team. They're an external partner. And that really is based on the level of communication and trust. And so you really have to work to get to the right level of communication and to the right level of relationship where the community health worker is valued. Also, we need to be very clear about the scope of practice. We can't ask community health workers to do things that they are not trained to do and not supported to do. We really have to be honestly very protective of our community health workers because they are really such valuable members of the team. Also, there really has to be a culture, and it's been mentioned all along the way here, but there really has to be a culture of training, supervision, and support that's ongoing. And we really do need to be in that support. Part of what we do here is reflective supervision. So again, reflective supervision really helps us when we're working with families that have a high level of trauma. And truth be told, we do have a high level of trauma for our families that we serve. And it becomes really important for us to be proactive and to address trauma, not only for our families, but also for our community health workers who often have their own trauma that they're working with. They also have their own social determinants of health. And so we can really look at this as a community development partner. Our community health workers can really be part of our community development as well as our childhood and family development. So they can be a very critical role and they need to be supported. And some community health workers will stay in that position and do a great job, but others can move into the positions that we need. And we do need a workforce that really reflects our population. So with that, Charlie, I'll turn it over to David.
Great. Thanks, Charlie. And hi, everybody. Pradeep, great to follow you. I want to bring a few comments also about leaning in to what community health workers can provide in terms of this space about advancing a relational health frame. And the COVID moment really has brought many revelations to all of us about the structural barriers for children, families, and communities, from the triple crisis we've all struggled with, the public health crisis, the economic crisis, and the racial reckoning. The stress on children and families by this movement has been harrowing, and ever still, the needs of young families from the challenges of stress that are experienced, and we're now witnessing it in the social, emotional, and behavioral challenges of young children and families, but also the mental health crisis. And, and we've heard, we're never going to go back to normal because normal never really existed. We're leaning forward in that opportunity of building back better. And I think that the comment that was made about the linking role of transformation of our health system to meet this moment in time from community health workers has never been more urgent and also critically important. Just in August, the AAP put out a policy statement called Preventing Childhood Toxic Stress, Partnering with Families and Communities to Promote Early Relational Health. And I call out the statement that was made, safe, stable, and nurturing relationships for families is challenging pediatric care to create a paradigm shift of the way we provide clinical services and research and advocacy. This work of community health workers' contribution to a transforming child health system, partnering with communities and equity in the moment of supporting families has never been stronger. And the criticalness of the community health worker movement being brought into the maternal child health space, the prenatal to 3 space, when the foundations of all future development, well-being, and future capacities are really start well on those fundamental relationships. The community health worker is that part, like as the ICMARC team has called out, that part of a relational health workforce. Partnering deeply with families to create trusting relationships as bridge into the platforms of the health system itself is really essential. Bringing that partnership of trust, the partnership of engagement, and most importantly, that sense of bringing connection of families to the supports that they need. It really takes a relational approach. And this relational health workforce is really a central part of that work. It's also a continuum of functions, everything from providing as navigators, partnering with families around the perinatal space and birth, like birth doulas, the identifying of engagement and bringing families to prevention service and support, serving as peer counselors, serving as navigators to the needs of systems, and serving of linking the health system's goal, pediatricians' practices goals of supporting the needs of families linked to communities is a unique opportunity. We have good models now in healthcare, in the high-performing medical home that views all of the work of primary care peds as a team-based care model. And community health workers have to be a part of that team. And as Charlie called out, it's so exciting in Washington State to now see that, in fact, under this recent state budget approved $2 million for a 2-year program to begin the addition of community health workers into child health pediatric practice. And a commitment they have also of looking at how can one explore long-term sustainable reimbursement, including looking at federal waivers. That opportunity of community health workers integrating into the transformation of child health care to meet this moment of what the pediatric community is wrestling with by the stresses of families that have to be supported by local networks to the resources that are local for families is really timely, exhilarating, exciting, and a game changer as to the opportunity in front of us. My call out is the criticalness of making sure as dollars roll out to advance the public health system redesign in this moment of time when we are desperately trying to recover and imagine a new world, that the work of the community health worker investments likewise are called out to be in the prenatal to 3 space so that we can really look at building the future well-being of next children focusing relationally. So Charlie, I'm going to turn it back to you. Thanks.
Well, thank you very much. And I'm now going to turn it over to Myra, who's the Executive Director of the Children's Partnership. And on the right-hand side of this screen is the report that the Children's Partnership just completed around community health workers advancing child health equity that I think is just a wonderful resource for people. I also really want to have people use the chat box to reflect and to provide comments or questions, and we will get into the discussion phase, and probably you'll want to hear more from some of the individuals who've presented or to provide your own views. So I just wanted to kind of alert you to that, but I do now want to turn it over to Myra.
Thanks so much, Charlie, and thank you for the opportunity to join you and this incredible panel of advocates for community health workers and community health workers themselves. I'm honored to be able to share a bit about the work in California to advance a community health workforce. Just to level set, for those of you that don't know the Children's Partnership, I want to share that we're a statewide policy and advocacy organization in California seeking to advance child health equity. And when we talk about child health equity, we're talking about just and fair inclusion into a society in which our kids are all healthy and they can participate, prosper, and reach their full potential. And that's important because that is directly tied to the conversation today about how community health workers can help advance that mission. Just a few years ago, about 5 years ago, almost 6, we released a report on the Affordable Care Act and its impacts on children. And in it, we issued a set of recommendations for the work we have left to do to create this more equitable healthcare system. And one of those top recommendations was to support a community health workforce. Fast forward a few years, and as we've discussed here today, the topic of community health workers have truly grown in recognition and opportunity. For those that have been working with community health workers for decades, we know that the concept of a community health worker, a promotora, is not a new concept. But we have an opportunity to seize now to ensure that every sector of our society is working to better address the needs of our diverse communities and really center equity in the work every day, especially in these last couple of years, as David referenced. We have to really consider what we can do to advance a more equitable approach in care delivery. For us at the Children's Partnership, we've been exploring how children continue to be harmed by racism that's embedded in and perpetuated by institutions, systems, and policies that shape the conditions that surround child health and well-being. We've been able to release a series of briefs that really consider opportunities to disrupt oppressive systems, to defer to community leadership, and to demand bold innovations that put the well-being of our children first. Our brief, Community Health Workers Advancing Child Health Equity, is the culmination of listening sessions that we hosted in English and Spanish with members of community health workforce across California, but also reflects conversations with partners who are leading the way in advancing health equity and research that highlights how a community health workforce is a key component of addressing and eliminating health inequities that impact young people from historically marginalized communities. So as we look together to advance equity in our health system and in every space that serves our kids, we must consider how we can combat racism. Anti-racist strategies are conscious and deliberate efforts that address and eradicate historic and present marginalization and inequality impacting our communities. And one of the most obvious ways to do this is through shifting power to the communities themselves. And that's exactly what a community health workforce does. It centers the people who directly experience the conditions that cause inequities and creates leadership roles and avenues for them to share their perspectives and recommendations with our healthcare system. And to Bree's points earlier, programs that support a community health workforce also shift power by both employing and then equitably paying a workforce that's mostly made up of people of color. I say all of this because this is what we try to do in our advocacy at the state of California for advancing a community health workforce. Just as background, California right now is in the middle of implementing a community health workforce as part of our Medi-Cal program or our Medicaid program, specifically through a state plan amendment that creates the policy under our Medicaid program under the Preventive Services Authority. And we are incredibly encouraged by the progress our state is making, and in particular, its commitment to children and families. I'll give you a few examples. They created a state working group to work with stakeholders to inform the process of the development of the state plan amendment. And I will say, traditionally, our state has utilized community health workforce with a focus on adults with complex conditions, the high utilizers of our Medicaid system, right? Who is costing our system the most? However, they did a notable shift in the creation of this workforce by inviting children's groups. And within that, pushing for child health and development to be included in order to see what progress we can make. Additionally, our state has released a Medi-Cal strategy to support health and opportunity for children and families. And within it, really referencing the importance of a community health workforce, again, to try and meet this moment, to David's earlier point. Our advocacy with the state has really been around 3 areas: defining the services that community health workers can employ, defining the service provider and their qualification, and then defining supervision. And in all of those areas, we've made progress, really seeking to broaden the definition of individuals who can be served by the new benefit, who can qualify as supervisors, and making sure community-based organizations that employ community health workers can be included, child-focused services and finding language that can be specific to child health and development. And then, of course, really looking to see that services can be provided anywhere, not just in a clinical setting, but in community settings, in schools, in homes, and in early learning and care spaces. So again, really moving that definition from individuals with a chronic condition to really moving upstream and thinking about the well-being and preventive nature that we need to think about when we're talking about child health. We were incredibly happy to see the inclusion of community-based organizations and clinics as being able to supervise community health workers. And then we also saw that there was an expansion to health education and training and health promotion and coaching that, again, could better identify community health workers serving children. However, we've got more work to do. We want to see as broad of a definition of community health worker as possible. For example, there are certain home visiting programs that employ community health workers and can really focus on the earliest days of a child's life that are a critical opportunity to lay the foundation for a healthy life overall, as well as the location where services are provided. We want to see more language that really focuses on spaces like schools and early learning centers that make explicit where CHWs can deploy these services. And then even broadly, when it comes to talking about services, we want to ensure that there is attention to the type of investigations that CHWs can perform. So thinking about what are the sources of a child's elevated blood levels, or what sort of connection to services, for example, enrollment service can CHWs conduct in order to, again, meet a child where they are. And part of these specifics are our upcoming opportunities in the creation of the provider manual. So there is more information to be done and more advocacy to do. And then finally, as we see the progress California is making to center equity in this effort, we're continuing to advocate for further disruptions to traditional care delivery. So for example, looking at school-based health centers as supervisors of CHWs in a mental health initiative that we have in our state. Making sure, to Pradeep's earlier point, community health workers are part of a child's medical home team and that care team that is so essential to providing a medical home. When I should flag, when 70% of the kids in our Medicaid program do not have a medical home, really focusing on a CHW and the role that they can play is particularly important. And then we also want to have a more dedicated conversation to billing and payment, really linking to the economic justice argument of the importance of community health workers. And then finally, as we really start to explore who we want to include, is the inclusion of CHWs with ITIN, individual tax identification numbers, really thinking about our large immigrant population in California and who they trust, and the need to really consider the circumstances of immigrant families. How can we make explicit our inclusion of CHWs and promotoras with ITINs to be able to provide these services? So again, we are encouraged about the progress and believe that in order to center equity, a community health workforce is a direct response to building a system that more equitably serves our children and families. And looking forward to the rest of the discussion. Back to you, Charlie.
Yeah, well, thank you very much, Myra. And I'm looking at the chat box and really encouraging you to put in your questions, observations, and thoughts, because we will be coming to the discussion section. And obviously, I think that there are things that we can discuss among ourselves and we can add more points. But I think if you've gotten anything so far from this, it's that there are some real champions who are doing this work and who know how it is done and can really help it be diffused much more widely and broadly. And I'm really pleased to have these people. And I just think, what if we had 150,000 more breeds out there of many different hues and orientations and nationalities, but really working in communities, how much better off we would be. I am sometimes introduce myself as the formerly Honorable Charles Bruner because I was a state legislator. And there were a couple things I learned in being a state legislator I think I want to use to introduce Kate. And the first thing is, if you want something done legislatively, you somehow got to find someone who can really champion it and understand it and work for it, who has that vision and standing with the colleagues. And certainly Bob Casey fits that bill and really has been a leader. And I'm sure Kate will say something about it. And the second thing is, go talk to Bob Casey, that's fine, but look who's standing behind him and look at his staff person. That's the person who is going to have the real knowledge and the depth and the wherewithal and the ability to make sure that as things move forward, the devil in the details are attended to. And what is that broad vision and marketing that is done by the legislator themselves really gets incorporated into the way programs and practices are designed and implemented. So really want to introduce Kate Samuelson, and I'm going to turn off the recording part of our discussion now and urge you to get in the chat box, but she's going to provide that update and context on what really is moving now in Congress and hopefully how we can make sure that it moves forward further and more boldly and with the type of funding that it needs to succeed.